Thanks so much for the invitation, and I know we have a small audience here, but we're small and mighty, and we are the choir, so that's fine with us. No disclosures. First, I think it's important to acknowledge that multiple demographic domains exist within our society, and it's those domains that experience underrepresentation in the vascular surgeon workforce in many instances that are identical to those that experience workforce vascular or worse vascular disease outcomes. We must also remain aware that our vascular care ecosystem is much more broad than just our physician practice partners, and our goals for EDI should reflect our broad reach if we think about our departments and our practices. I think this is a very important point, that it's somewhat naive of us to accept that much work still needs to be done to educate ourselves on the value of a diverse and representative surgeon workforce. We sit here with the choir like this, and we believe that everyone agrees that this is an important topic, but that's not the case. We need look no further than the findings of this STS task force to understand the range of opinions regarding the topic. When asked an open-ended question about opinions on EDI efforts, here are some of the responses submitted by the STS membership, and I'll let you read for yourselves. I particularly like the last one there. There are no barriers, none of the above are important. Statement. End of story. As proof points of the lack of diversity within our specialty, Dr. Olivola and many of the podium members today, as well as Dr. Dorsey and some of the work she's already presented this morning, have provided evidence around the current statistical landscape in vascular surgery. And this is somewhat problematic. We hope that there are some forthcoming updates on this, and we hope that we made some improvement over the last couple of years, but we can see how the numbers are relatively dismal in terms of the representation in leadership and on councils within our very own society. I expect that this has improved over time. As an additional proof point, there are long-standing and definitive evidence that a lack of physician diversity and cultural competence harms patients. And additionally to Dr. Dorsey's publications that she cited, this is a very important publication, many years old, published in the New England Journal of Medicine in 1999, that really described a significant disparity in how patients are presented. Actors presenting with the same clinical presentation for coronary artery disease and an acute MI were treated significantly different. Black patients and women were much less likely to receive a heart cath, not a delayed heart cath, but even receive a heart cath with the same presentation. And while one may say that that's a dated study, here are data from 2019. This publication demonstrates that much remains the same. When we look at 1.5 million patients from an NIS data set, we see that the variables associated with delayed rates of catheterization and delayed time point for catheterization include women, Black Americans, and the lack of private insurance. The culprits to workforce diversity are multifactorial, including supply-side issues across URIM groups, low numbers of URIM learners within the pipeline that's been previously described, are consequences of many systemic barriers that begin at the earliest steps of the necessarily arduous progression to physician training. And structural barriers are present within the various gatekeeping points in the journey. And frankly, this is the resistance to change that's articulated in the constant refrain of our leadership. This is how we've always done it, and up to now it's worked very well, so why change? So we've talked about some of the problems, some of the culprits. What are some strategies to enhance diversity? It begins with understanding that diversity or medicine is a funnel. And we expect that. It's competitive, and it's not a pipe. But our efforts should be directed at flooding the funnel with the most talented, hardworking, and diverse individuals and keeping them engaged with our wonderful profession. The deep pipeline is very important, as Dr. Dorsey described in the previous talk. Most of the evidence in STEM research suggests that children have turned off from math and science by grade 4. In our respective local communities, we as vascular surgeons need to create and support programs that provide access to health science role models for young people. I know many of you, Dr. Brewster and others in this room, are already doing this type of work. We must unselfishly engage the pipeline. That is, first as a scientist advocating for STEM, as a physician advocating for medicine, and then as a surgeon for our beloved specialty. And I'd say it's not a failure to mentor a student who goes on to be an engineer, or frankly, even a cardiologist. Many medical societies, community organizations, and medical schools have existing programs and are available for partnerships. And in the context of our Vascular Surgery Society, this is a shameless plug for our newly formed Society of Black Vascular Surgeons. Within SVS, we should look to create a repository that enhances the visibility and collective synergies of these existing programs. And we have to mentor relentlessly, not only within our local spheres of influence, but via virtual tools, and of course, social media. And as I understand from my children, this does not mean the Facebook. I can't overstate demographically concordant mentoring is great, but the numbers just don't work out. And we should refrain from being paralyzed by demographics in this context of mentorship. Meetings like this are fantastic with regards to seeing a young person and pulling them aside and showing them that they're welcome to attend this meeting, and you hope that they're engaged in the society. Finally, as a professional society and specialty, we must advocate for broad-based and holistic evaluation of medical school graduates for our GME programs. And I'd say we should begin by moving away from the concept that, quote, I can't put my finger on it, but there's something I like about him that makes me think he would be a good fit within our current fraternity. We must unceasingly begin to recognize that implicit bias is an important issue that we all walk around with. None of us are excluded from having this trait. To do this intentionally, multiple tools exist, including the implicit association test that I would recommend become mandatory for all vascular surgeons, given the diverse group of patients for which we care. The SVS can give us a little nudge in this effort with a carrot of a cultural competence certification for our practices and our departments. This is the Cultural Complications Program, which many of you may already know about. It's developed out of the universities of Maryland and Michigan, and it's a great tool which provides a broad-based curriculum on cultural competency. And much of it is along gender lines and non-race and ethnic lines, and it involves short vignettes which can be delivered in kind of a M&M format. And this is a tool that one of my classmates at The Ohio State University, who was the previous dean at the school, designed for medical school admissions teams to utilize at a time of student interviews to mitigate implicit bias. It's actually cards that they pull out to kind of sensitize themselves as they're interviewing candidates. And it extrapolates nicely to our GME interview process. And I think this is a really important point. Establish EDI as a GME priority by weaving it into a top 3 variable for rank list creation. And let's do away with what we call the field of dreams philosophy, that idea that if we build it, they should come. And it comes from the inherent belief that we all have great vascular training programs, and so the cream of the crop of women and URIM candidates should just organically appear at our doorstep. Mentorship, allyship, sponsorship. Each one of us, no matter our background, needs all of these to become the best version of ourselves. Women and URIM students, EDI programs need these at an institutional and a societal level. And within our departments, we should be providing these in a structured and intentional way for all of our faculty. And finally, and when these individuals are doing the EDI work, in whatever capacity it takes at your institution, please look to provide them the leadership support and the necessary resources, including administrative and financial capital, to avoid what's commonly known now as the minority tax. I guarantee you that as these people are doing this work, they also have other valuable clinical and leadership skill sets, and these skill sets should be developed, because as we all know, no one wants to be a one-trick pony. Thanks.